Hello guys, welcome back to my channel. At this stage in time, a lot of you have done your PSA, so shout out to all of you. In this video, I thought it may be a good time to get ready for OSCEs, and something that I found really helpful when I was prepping for my OSCEs during this period of time was to really focus on these videos by Geeky Medics, and I thought that we could break down this one on our mental status exam for depression. In my uni, we don't really have mental status examinations. We just have like classic psych histories. Then you have to ask the right questions and then gather what you think is necessary to make the diagnosis of depression or bipolar, or something of that sort. And then obviously like to grade the level of depression, if it's mild, if it's moderate, if it's severe. Have you red flagged them? Have you safety netted that patient? Those sort of things. Have you taken a proper social history? So I thought that this would be a good chance for us to go through this, also go down memory lane. And last year I had to retake my OSCE, so I was watching all of these videos and I found a few of them really helpful. So I'm going to go through a few of them in these next few videos. Whether you're seeing this on YouTube or TikTok, then please watch. Let me know if you like this, if you want to see more, especially in the lead up to finals. I know a lot of you have finished, but for those of you that haven't finished, especially a lot of my friends at the uni that I went to for med school, I am making this video for them. So let's get into this, guys. Let me turn off the fan.
I'm Jade, I'm one of the doctors from the psychiatry team. Can I please just check your name and date of birth? It's Jane Sheraton.
Just straight off, a lot of you may not even have like the mental state exam come up, but just from the history, I would say if you see the demeanor of the patients being quite like down and they're not really making eye contact, I think you really need to focus on, is this station in psych history? Because especially for our stations, the psych history came up in a station that was a patient that is pre-op for surgery for the ankle. So I was not prepared for this sort of history at all. So I would just say, if this is you, if you're in this position, focus and adapt your speech to meet and to suit what the patient's speech is, especially in final year, because obviously they assume that you know most of the questions already. They want to know, are you a good doctor? Can you make the patient feel comfortable enough to pull that sort of information from them? And also, again, if you want to practice, go on Dr. Prepper Dakota UK. There's loads of cases there as well for psych.
It's the 3rd of May, 68. Okay. And I've been told that you've come into hospital because one of your friends was worried about your mental health. Is that right? Mm-hmm. Yeah. Could you tell me a bit about how you've been feeling?
Nice open question.
I just feel really, really sad. Just sad. Yeah. Mm-hmm. How long's that been going on for? A few weeks now.
Enough of times with these questions, you'll need to ask a few more questions to really get the patients to sort of open up and tell you what's going on. So if you ask them what's going on and they're like sad, or they give you like a one-word answer or a statement that doesn't really like lead you to anything, don't be afraid to keep going on along with your history, because there's still questions to ask for your psych history to get those marks. But don't be afraid to re-ask the question a few minutes in, once like you've built a bit more of a rapport with the patients.
Is there anything in particular that's been going on recently?
So I lost my job. I really love that job.
That sounds really, really difficult.
It is.
Yeah.
It's really hard.
You can see the doctor is almost mirroring the patient as well.
I guess, that all sounds like there's a lot going on. Have you been able to kind of do anything you enjoy?
I don't do anything. I don't enjoy anything. I don't do anything.
And now we're like going through questions that are necessary to ask to diagnose what this patient is like going through. So You know, is she enjoying things that she used to enjoy, or is she no longer enjoying things that she used to enjoy? Does she have a lack of energy? Is she waking up earlier than usual? Is she going to sleep later than usual? Can she stay asleep for 6-7 hours, or is she maybe sleeping for 3 hours max? Has there been a change to her appetite, either eating a lot more, eating a lot less? You know, 3 or 4 of these questions is good to ask to, you know, to screen for like depression. And then obviously trying to, you know, to ascertain like the time course, and then ascertain maybe in like the past if there's any like period where she's had like the opposite of these symptoms, almost, where she's had like increased elevated mood. She was very euphoric, you know, she felt like she had, you know, delusions of grandeur, you know, just to rule out maybe is this a case of like low mood in the context of, you know, bipolar? Is, you know, is this not bipolar? Then, you know, maybe even go to, you know, is it like what type of bipolar is it? You know, type 1, type 2.
Don't
You
do
know,
anything anymore. I just I just cry. I just can't stop crying.
anhedonia.
What kind of things would you have done before?
I'd see friends. But I don't have really friends now.
So is it that like that lack of a support system?
I'd go running, but I just don't.
This also falls into
Don't have
anhedonia and energy,
fun or-
lack of energy. Not really enjoy things she used to.
Okay. Have you been sleeping?
I just sleep really bad because I just keep waking up and just
Insomnia.
thinking about just how bad I am. I've let so many people down. I can't sleep. I've just let lots of people down.
Okay. Why is it that you feel you've been letting people down?
It's good to explore as well. Like when patients often give you like these cues to ask for the questions, oh, I feel like I've been letting people down. It's good to also be focused on like the structure that you have in your head, and you know, like you're going through the presented complaints, the history of the presented complaints. You're like then diving into like her psych history, and then maybe you'll ask a few questions to rule out other forms of like psych conditions, like, you know, to rule out bipolar, you know, to rule out like and depression. Maybe even ask some red flag questions on the severity of like depression. But when the patient gives you a cue like, I feel like I'm letting people down, it's really important to pick up on that cue and to ask for the questions like this doctor did here.
Well, I've lost my job. It must be my fault. I left the team down, and I've just really let my son down because I've got no more money now, and I just really want to pay for him, you know, for university, and I'm just a really bad mum because I can't afford to now. I haven't got a job.
Just in terms of with the way that you've been feeling and everything that's been going on, have you been managing to look after yourself?
Maybe also that part after like the patient has opened up, it's also worth a shot to go back and like to say, you know, thank you so much for what you've told me, you know, I appreciate how difficult that must have been, but I do want to, you know, to stress the fact that you are in the right place, and I'm happy that you're here. I just have to ask you a few more questions, but I'll do my best to come back and to address those points that you've made in regards to her son and feeling like she can't look after him, and, you know, the lack of support with her job. Maybe even if you feel brave as well, maybe offer like some support there as well, to say, you know, we could put you in touch with some teams within the hospital, some social workers, to see what they can do in terms of helping you to, you know, with work and, you know, with funding, if that's something that you would need. Even if she says no,
I
it's
just
good to
can't be
offer.
bothered. Just don't see the point.
Have you been eating?
No. No, just some, just a bit of toast.
Okay. Sometimes when people have been dealing with things like this, they might try drugs or alcohol as a way of coping. Is that something that you've tried?
No.
And have things ever felt so bad that you've thought of harming yourself or
Risk
ending your
assessment
life?
is key for any psych station.
Yes. I do. I'm really sorry, Doctor. I'm really sorry. I'm just.
It's okay. I'm sorry. I know it's a really difficult thing to talk
No, I'm just sorry to waste your time. I'm just not worth helping. There'll be other people. There's other people that you should be helping, not me. I'm just not worth it.
What is it that you've thought about doing?
Well, I mean, I don't know if I'd actually do it, but I've just been buying paracetamols.
Okay.
I just don't think things are going to get any better. I'm just so sad.
Had you made any plans to take those pills?
Yeah, very good questions to ask. Has she made plans? Has she told anyone? Has she ever attempted to harm herself in the past? Has she attempted to end her life in the past? Does she have any
I don't know
protective
if I
factors?
would, but
Family? She has a son.
I did feel so bad that I just thought I should maybe write a note for my son, or yeah, I did think about checking my will. I mean, I don't know if I would do it, but I did think.
Is there anything that would stop you from doing something like that?
I don't know. I don't think so, because I just don't think anything's going to get better.
Have you had any thoughts about wanting to harm anyone else at any point?
Does she feel at risk of harming herself, harming other people, or for anyone harming her? Very good question to ask.
Hear or interfere with your thoughts?
This is just
or-
assessing for other sorts of psych conditions. Do you hear things that people don't hear? Do you see things that people don't see?
Controlling your thoughts or what you do?
Yeah, this is also screening for schizophrenia, thought insertion. You know, do you hear, thoughts or voices from people animating, saying what you're doing?
Things they can't explain.
Do you see or hear things that people can't see or hear?
No.
Then just a couple of questions. Do you know where we are right now?
Yeah.
Yeah, would you be able to tell me?
I'm just with the A&E that my friend brought me to.
Yeah. And do you know roughly what time it is?
It's about 6 o'clock.
Yeah. And can you remember who I am?
I've forgotten your name, but you're the doctor.
Yeah. Do you think it's possible that the way you've been feeling recently might be affecting your thinking?
I know I'm depressed, but
Yeah, assessing insights. What does the patient think of her condition?
I just
How does she feel?
things won't get better.
Is there anything that you think we could do to help you that might help you get through this?
I just don't think anyone can help. I don't think anyone can help. I don't.
Well, thank you very much for speaking to me today. I know that must have been really difficult to talk about. I think it'd be best if I go speak with my team to see what we can do to help you. Would that be okay? you got any questions for me at the moment?
No, thanks.
No? Okay, well, thank you very much for speaking to me today. Today I assessed Jane Sheraton, a 48-year-old lady presenting with low mood and suicidal ideation on a background of significant social stresses. For the last couple of weeks, she has been struggling with suicidal ideation and has been stockpiling paracetamol. She states that her friends and family would be better off without her. On examination, she appeared sad and tearful, with poor eye contact and evidence of psychomotor retardation. Jane's speech was slow and monotonous. She described her mood as low, with evidence of anhedonia, poor concentration, and early morning waking. Her affect was blunted. Jane described mood-congruent cognitions of hopelessness, burdensomeness, and guilt. Her thoughts were linear, and there was no evidence of formal thought disorder. She denied any perceptual abnormalities. Jane was oriented to time, place, and person. Jane demonstrated partial insight, but she does not believe that her cognitions of guilt or hopelessness could be related to a mental health disorder. In terms of risk, Jane reports ongoing thoughts of suicide with plans to take a paracetamol overdose. She is at risk of self-neglect due to struggling with self-care. She denied any thoughts or intent to harm others.
If you enjoyed this video, check out the Geeky Medics collection of over 500 OSCE stations and put your OSCE skills to the test. Okay. You can practice with...
Or you can go to drprepper.co.uk and practice these stations. The summary at the end was very, very good. Again, some key things to mention. Quick summary of what happened. One line stating who this patient is or why they're here. This is I forgot her name and age, but this is Sarah Crawford, a 73-year-old woman that comes in with a low mood, and then the next line saying the key positives that she has. She has anhedonia, she has energy. Some more things to say. She's had suicidal thoughts, but at this point there's no plans to end her life, and she has some protective factors being like her son. Some key negatives. She's never tried to attempt to end her life in the past. She has no history of being involved with the mental health team. She has no history of being involved with a social worker at home for her kids. I know that wasn't mentioned here, but that would be some very good questions to ask there. There's no history of drug or alcohol use, which are also very, very key. Again, for different histories or on different stations, different questions are more useful. So for this station, you really need to lock into the social history to really just make sure that you're being thorough with whatever is going on there. And then at the end, go through what your top differentials would be. Depression, bipolar. Then maybe lower down, you'd have maybe just some form of anxiety, but it's most likely depression, as you have some key factors, seeing the DSM-5 when you're looking to diagnose depression. Then go through your investigations on your management, MSc exam. You'd want to get the involvement of a senior. If your hospital, maybe get involved with liaison psych. If you're worried if there's red flag features, if she's coming with an overdose, and you're worried that she's going to go home and try to end her life, or if she's at risk of harming her children or being harmed for someone else, then you definitely want to escalate faster. Maybe even look to do a section, but of course you'd still need senior doctors to come on section, unless she agrees to stay voluntarily. I think there's a 72 hour section that you can do as a junior doctor. I completely forgot which ones the names are, but escalates to seniors. Still assess her mentally and physically, so baseline observations on blood tests to screen for other things that could mimic this, FBCs, to look for anemia, which could mimic the low energy, TFTs to look for hypothyroidism, which could also mimic low energy. Maybe do CRP white cell count to see if there's some form of infection. If you're worried about sepsis from the blood, maybe do the sepsis 6, but of course infection looks very low. She's not complaining of any systemic symptoms. Also correlate with her OBS as well. If there's something that you're worried about, maybe increase reps rate. If she's tachycardic, if she has low blood pressure, all these things can lead you down the path of if this is more medical as opposed to being more psych based. Then as you keep and progressive, then look to manage her. So you know, you want to do things like, you know, acutely CBT, involvements with liaison psych, long-term, intermediate term, have her to be referred to the GP for sertraline, or maybe even start her on sertraline there. If this is like moderate depression, or maybe even if the patient would like to start medication, maybe she's tried CBT in the past and she'd like to start medication, but also counsel her that she may feel worse within the first like 2 to 6 weeks, and it would take like 6 months or so for the sertraline to work. You know, all of these different things are, you know, are what you would mention. Again, this was not really what would be useful for a history, but it's an MSc exam. It's not a psych history, but I wanted to talk over it to say the different things that you'd add if this was a psych history. You know, because of course a lot of you may not get a mental state examination. But yeah, guys, I hope this makes sense. I hope this was a good, you know, station, a good history. I hope you got something out of this. If there's more that you'd like to see me do in the future, then please let me know, and I'll make more of those videos. But for now, I will leave you guys to it. That is it for now. See you later.